Welcome to the National Retiree Legislative Network 2022 podcast series titled Creating a Better Future for Retirees, produced by and for American retirees and those over age 50. I'm Bill Kadereit, president of the NRLN and your podcast host. If you want to play any of our podcasts, go to NRLN.org, click the NRLN videos and podcast color icon in the middle of our homepage, then select any episode title you wish to play. On the NRLN.org taskbar, click the Contacts tab, then select Contact the NRLN, where you can send an email or call toll-free 866-360-7197. Offer comments, questions, and suggestions, and we will be happy to respond. Our goal is to present and discuss current and future income security and healthcare concerns important to current and prospective retirees in a factual, nonpartisan podcast format. Many of our white papers and position papers relate to our podcasts. They are listed under the homepage Legislative Agenda tab. When we analyze universal issues like Social Security, Medicare, Medicaid, and subjects like prescription drug costs, we rely heavily on quotable information from U.S. Census reports, Social Security and Medicare trustee reports, Medicare Payment Advisory Commission reports, and the Center for Medicare and Medicaid Services reports, and other verifiable information. Sign on NRLN's website to get emails and podcast schedules there and on Facebook at www.facebook.com/NRLN/ our podcasts are posted on YouTube also. Now, welcome to today's podcast. It's 2022 podcast series titled Wall Street's Takeover of Medicare. I'm Bill Kadereit, president of the NRLN and your podcast host. Today, we will review how Medicare Advantage plans and direct contracting operated by corporate health insurers have led us to an attempted Wall Street takeover of traditional Medicare. I asked Ed Beltram, the VP of Communications for NRLN and our research partner, American Retiree Education Foundation as well, to collect information about how the direct contracting effort started and who the players were who created direct contracting. Welcome, Ed.
Most of the mainstream media has not reported on direct contracting. However, there have been a few articles and opinion pieces. I'll talk about them after you tell us more about the efforts to privatize Medicare.
Okay, so here we go. You know, in 2008, Warren Buffett was quoted saying, "The ballooning cost of healthcare acts as a hungry tapeworm on American economy." Notice the emphasis on cost of healthcare. Folks, that tapeworm has morphed into a piranha called privatization at any cost. Medicare Advantage, corporate Medicare coverage has not reduced healthcare costs, and direct contracting, a new form of corporate Medicare coverage in original Medicare this time, may be an even bigger disaster. There's not much difference between these two, so let's take a look at this. They both operate under the same laws and rules, so they're governed the same way. They serve the same customers, you and I and everybody else in America over age 65. They're incented by the same phony payment plans, like the 5-star plan that gives them their rebates and bonuses. They deal and they have the same ability to steer people to poor quality, low-cost specialists and delay and deny care inappropriately in order to maximize profits. They use the same suppliers, people that make hospital beds, hospitals themselves, and doctors. So what's different? You have to ask yourself a series of questions here. Will they effectively limit your ability to get care from doctors and hospitals you know and trust? Will your premium, deductible, copay, or coinsurance costs increase? Will your out-of-pocket costs increase? Will you not get the services you need? How will your claims be managed? Can we expect more claim denials by unknown companies owned by Wall Street startups? Corporate control of health insurance and Medicare has driven up cost and jeopardize access to quality care. Notwithstanding, our government has opened original Medicare up to a new parasite, Wall Street firms or direct contracting entities overseeing our coverage. And it's poised to poach more taxpayer dollars and restrict access to services. We overpaid Medicare Advantage plans by over $40 billion of our personal tax dollars in 2021. And Medicare trustees forecast that phony cost-sharing bonuses and rebates will cost Americans $100.8 billion in 2030. And here's what we got back so far: higher Medicare Advantage costs and questionable quality of services. We must convince Congress and the White House to abandon this Wall Street takeover of Medicare and instead declare war on healthcare costs. That's the tapeworm. We will continue to unearth more facts about this direct contracting experiment on people in original Medicare and report them to you in our monthly emails and subsequent podcasts. Sign up at www.nrln.org to get this information. So Ed, maybe we should take a jump shift here and talk a little bit about the knowledge that people have as of today about direct contracting and direct contracting entities. Can you tell us about an article that I had read, an Intercept article, I believe? It was titled "Medicare Privatization Scheme Faced Legal Questions About Profiteering."
The Intercept article shed light on the political conniving and the money interest involved in the creation of direct contracting. Here are a few of the revelations from the article. Late in the Trump administration, direct contracting, a Medicare privatization scheme, was set up by a guy named Adam Bowler. He was director of the Centers for Medicare and Medicaid Innovation, also known as CMMI. And get this, Bowler was a former dorm mate of Jared Kushner. If that name sounds familiar, it's because he's President Trump's son-in-law. The Office of the General Counsel for Health and Human Services Department warned that it appeared that direct contracting was being set up to benefit specific companies. Bowler, prior to working in the Trump administration, ran a startup called Landmark Health, which was backed by a venture capital company, including the firm Oxen. That's spelled Oxeon. Under Bowler, CMMI, the innovation part of CMS, contracted with Oxeon to recruit the staff for CMMI. Later, Landmark Health announced it would be contracting with CMMI to become a direct contracting entity, or DCE. Brad Smith, a recruit of Bowler's, who briefly served as director of CMMI after Bowler was appointed to an unrelated position by the Trump administration, launched a healthcare company, Russell Street Ventures, in June of 2021. That company is now directly contracting with Medicare. Adam Slavic, President Obama's head of CMS, was linked up with Oxeon for one of his own direct contracting entities. Richard Gillifan, the head of CMMI from 2010 to 2013, and Donald Berwick, a former head of CMS during the Obama administration, published a paper in September warning that many of the waste-generating elements of Medicare Advantage program would carry over into direct contracting.
Well, Ed, that kind of covers the kind of a pre-conspiracy review, I would say. I'm sure that a lot of people won't be happy to find out that Wall Street had penetrated our own executive branch agencies. But in general, what else has been in the news about in the media about direct contracting that most people might not know about?
There have been a few articles. There was a strong opinion piece opposing direct contracting in the Washington Post on December 14th, 2021. And in the Hill newspaper on December 19th, December 9, 2021. The Washington Post said that direct contracting is a backdoor attempt to further privatize Medicare. Corporate interests are lined up like pigs at a trough to get their hands on taxpayer dollars. The op-ed concluded the Biden administration, which could easily stop this, is instead continuing Trump's scheme. I'll cite just one relevant point from the Hill op-ed, which also opposed direct contracting. If left unchecked, the DC program could radically transform Medicare without input from seniors or even a vote by Congress.
Yeah, that's interesting as well. And I've read in a couple of places that there are a lot of members of Congress who've never even been advised about this direct contracting or direct contracting entities. You never know whether that's the truth or not, but in general, are there any members of Congress taking a position on direct contracting?
Well, actually, Congresswoman Pamela J. Paul, who represents the Washington State 7th District, co-authored the Hill op-ed with Dr. Susan Rogers, MD. And so she was speaking out on it. And also there was 4 representatives who wrote a letter to the administrator for CMS and to the HHS secretary to express their concerns about direct contracting. Among their concerns were a lack of oversight to protect Medicare beneficiaries' care, beneficiaries who chose traditional Medicare over Medicare Advantage will be automatically enrolled in DCE. Another point of their concern was it's unclear how CMS will ensure beneficiaries will be able to switch back to traditional Medicare. It's also unclear how CMS will monitor impacts to beneficiary access to care. And they also were concerned that DCEs create an additional risk for beneficiaries without adding value. They concluded their letter asking that CMS immediately freeze the harmful DCE pilot program. The CMS administrator responded to the letter, but the bottom line is she did not stop or delay DCEs as the representatives had requested. Congresswoman Porter also has produced a video that is on YouTube, which details her opposition to direct contracting. There may be other members of Congress who have stated their position on direct contracting, but research by the NLRN and the AREF has not come across their statements.
Yeah, so at least some interest is beginning to bubble up there. How about what we've told the NRLN members? So maybe share with the audience what we've told our NRLN members so far about direct contracting.
An NRLN action alert was issued on December 7th, urging NLRN members to email letters to President Biden and their representatives and senators to demand that they kill direct contracting that would destroy Medicare.
Right. And we're going to say later, of course, that our podcast is going to be viewable on YouTube as well, and our Facebook site as well. And we'll be talking more about that later. So thanks, Ed. One comment here is that, in a minute, you're going to hear more about direct contracting and the impact it could have on 40 million seniors in original Medicare. And as you listen, you want to keep in mind maybe 3 points of general interest. First, Medicare Advantage plans have not improved healthcare quality. Instead, they have increased Medicare spending substantially and have been found to be inappropriate in delaying and denying people the care they need. Secondly, there are no facts, results of any kind, or specific promises on the table to indicate that direct contracting will be able to create a better track record than Medicare Advantage plans have. And third, and kind of interesting, is that people are willing to stick their necks out and spend more of our money here. Direct contracting may prove to be a costly failure, just as Medicare Advantage plans have been. And we will have lost hundreds of billions of dollars in valuable years. Likely also tens of thousands of lives prematurely because of the barriers to health care. When we could have applied the billions to innovate, to lower our fee-for-service costs under the original or traditional Medicare, as they're called. Medicare Advantage plans now hold 44% of the original Medicare market, and they hauled in $370 billion in revenue in 2021. Why ask taxpayers to coddle healthcare insurers any longer? Why not? Why should we be paying any subsidies to an organization that has a 44% market share and that kind of revenue? It's time to eliminate bonuses and rebates for Medicare Advantage plans and tell these insurance companies to put the big boy pants on and compete the American way. In the spring of 2021, the government began paying companies called direct contracting entities to cover care for people in original Medicare, even though these people specifically chose not to have a private firm administer their coverage. To discuss the health and financial impact that Medicare plans have and that DCEs are likely to have on seniors in America, I've asked Jim Bodenner and Diane Archer to explain more about how DCEs operate and the potential threat they present to seniors' health care plan availability, ability of choice, cost of care, and long-term availability of Medicare. Jim Bodenner is the president and executive team member of the NRLN Villages chapter and a retired attorney. And prior to retiring, Jim and his wife Susan built Bishop Hills Elder Care Community in 1996. It's a 47-bed home for the aged in Rockford, Michigan. Jim sold the facility in December 2012 and moved to sunny Florida. He's a member of the board of directors of Langley Health Services, a past director of Pure Water for the World, and a member of the Evening Rotary Club of the Villages. Diane Archer is founder and president of Just Care USA, an independent digital hub covering health and financial issues facing boomers and their families and promoting healthcare solutions. She spent her entire career advocating for consumers. She began her career in health advocacy in 1989 as the founder and president of the Medicare Rights Center, which is still operating. Since 2005, she has worked on a range of health policies and health advocacy initiatives, and Diane is a board member of the Benedict Silverman Foundation and has served as the chair of the Board of Consumers Reports. So welcome, Diane and Jim. And let me start off our questioning session here by asking Diane first. Diane, you're probably more just well-versed than anyone here on this program. Can you tell us what a direct contracting entity is and how it operates?
Sure, I'm going to do my best to be as clear as possible here, but it can get very confusing. So bear with me and I will do my best. What direct contracting entities can be are insurers or private equity firms that are paid by the federal government to manage care for people in original Medicare. And whose care are these insurers and investors managing? They're managing care for people whose doctors, whose primary care doctors sign up to be part of a direct contracting entity. So that means that if your primary care doctor is part of an insurer or private equity firm that has a contract with original Medicare to manage care, that you will automatically be assigned to this direct contracting entity, which works a lot like a Medicare Advantage plan.
Diane, how are DCEs paid?
So they are paid exactly the way that Medicare Advantage plans are paid. They're paid a flat per person rate to manage their care. If that's what they want to do, manage the total care package for the people who are in their DCE. They therefore have a financial incentive to spend as little money as possible on their enrollees, because the less care they provide, the more they can pocket. So how did they do that? They do that the same way Medicare Advantage plans do that. They can delay care, they can deny care inappropriately, or they can steer you to care that's less costly. So for example, your doctor might want you to have an MRI, but they might suggest that you have an X-ray. And even though your doctor may think that an MRI is reasonable and necessary, you'll start off anyway with an X-ray, which may not meet your needs. And what's different about direct contracting entities is that they are allowed to pocket as much as 40 cents of every dollar that the government gives them in overhead and profits. And so the concern we all have is that with these insurers and investors in charge of people's care, corporate profits and not the health and well-being of people with Medicare is going to become the top priority. And it's also not clear as a result whether the doctor who you've seen in the past is going to refer you to the same kinds of care the doctor would have referred you to in the past, now that the doctor is working for a direct contracting entity. Instead, the doctor may have to follow the rules that the direct contracting entity set in terms of the care that the doctor decides you should have. The one piece of good news is that if you on your own independently want to go out of the DCE and see whatever doctor or hospital you want to see, Medicare will continue to pay for any service that you receive that's a Medicare covered service.
Diane, this is really just absolutely overwhelming to hear. About 40 million of us around the United States, about 55% or so, understand that Advantage plans are not how we want Medicare coverage. We want original Medicare. We want the choice. We want to direct our own medical care. And it just seems to me that this whole process is going to eliminate 40 million of us from the finest Medicare coverage available. Those of us that are informed understand that a Medicare Supplement F or a G plan are the only way to get your Medicare if you want the best Medicare available. And I fear that that's at risk in this process.
All right, so let me first quell a little bit of those fears so that people understand where we are in this process, and then get to, as you suggest, what could happen, the really horrendous results that could happen over time. At this moment, we understand that there are several 100,000 people who are now enrolled in a direct contracting entity. And these people may not even know that they're enrolled. They still have their Medigap to help cover their costs that Medicare doesn't cover. And their Medigap works whether they're in a direct contracting entity or they're not in one. And they need that Medigap to cover their out-of-pocket costs and to protect themselves financially. So you can still get your Medigap, and you still should have your Medigap coverage if you're in a DCE, because that's the way that you can go get care without worrying about your out-of-pocket costs. the Medigap G, as you mentioned, Jim, will pick up people's out-of-pocket costs. So right now, there aren't that many people in these DCEs. However, the DCEs are right now also scooping up as many primary care practices as possible. So over time, as you suggest, 40 million people could end up in these DCEs if they're not stopped. Why are they so concerning? They're concerning because when private equity is in the mix, for example, what we have been seeing in the last few years, whether it's for dermatology practices, emergency room medical practices, long-term care practices, dental practices, what we're seeing is that they are getting involved in the kind of medical services that are offered, and they're keeping healthcare providers from delivering the services they think their patients need. And so the worry is, again, that your doctor, under the control of a direct contracting entity, becomes a different kind of doctor and doesn't refer you to Sloan Kettering or Mayo Clinic or Shands when you need costly medical care, but rather suggests you go someplace else. Now, the good news is that even if your doctor suggests you go someplace else, you have every right, if you're in a direct contracting entity, unlike a Medicare Advantage plan, to go to the doctors and hospitals you want to go to. You still have that right. So the question only becomes whether you want to stick with your doctor in the direct contracting entity, knowing that his or her job is to reduce spending on your care, maybe appropriately, maybe not, or whether you have the energy and the ability to switch doctors to a doctor who can treat you the way he or she believes you should get treated for your healthcare needs.
Diane, today, Medicare Advantage plan enrollees can't buy a Medigap plan, as you know, which is a supplemental coverage. Will DCE sell Medigap plans, and can DCE enrollees buy one?
So the good news is, if you're in Original Medicare and you've signed up for a Medigap plan, you have that Medigap plan, and that you buy in the individual market. If you can also have Medicaid or retiree coverage to fill gaps in traditional Medicare. The DCEs have nothing to do with that. The DCEs are simply paying for the care that Medicare would otherwise pay for, managing that care. So yes, you can have Plan G or any of the other Medigap plans. You can continue to buy it in the individual market. The thing you want to be aware of, though, is that if you drop your Medigap plan, depending upon the state that you live in, you may not be able to get it back. And that can be a big problem. So hold on to that Medigap plan so long as you want to have the freedom to go to Shands or Mayo Clinic or to some specialist who is outside the DCE, your direct contracting entity's network, or if you're not in a direct contracting entity, just to be able to go to the doctor or hospital without worrying about your out-of-pocket costs.
Diane, what's frightening to me, I'm here in the Villages in Central Florida. We are the largest 55 plus community in the world, about 150,000 of us. And you can bet that out of that 150,000, 75 or 80,000 of us are wise enough to have Medicare supplement F or G plans. We need to be dialogue. We need to be educating folks here in the Villages on what is happening here. There's no debate going on in Congress about this process. It's just happening administratively. What do I tell the guy on the street? What do I tell that person that is looking, in my mind, for three basic questions? What's my monthly Medicare premium going to be? What are my maximum out-of-pockets expenses that I can incur in any one year? And the most important thing, I believe, folks want to know, can I, without restrictions, go to any Medicare provider in the United States? We're blessed here in Central Florida. Within a short drive, we can access the best medical care coverage in the United States. Mayo Clinic in Jacksonville, Shands in Gainesville. We have Moffitt over in Tampa. We have the best medical care here. And if there's any thought that we're going to limit Medicare coverage to Medicare supplement, original Medicare recipients, people will go crazy. People will go absolutely crazy. And no one is talking about this. No one is talking about it authoritatively, and that is absolutely frightening.
It is frightening, Jim, and hopefully the conversation will be ignited by this podcast and other media outlets that are now increasingly talking about this Medicare experiment. And as I mentioned, it's still relatively small, but as you suggest, it can blow up and be pretty big pretty quickly and pretty scary pretty quickly. But what you can tell people right now are a few things. Number one, their out-of-pocket costs should not increase at all. However, they need to be sure that their doctor is not a part of a direct contracting entity, and to know that their doctor is advising them about the care that they need and ensuring that they get the care they need from the specialists and specialty hospitals that are best able to provide it. If their doctor is part of a direct contracting entity, they really need to think twice about whether they want to stay in that entity, largely because, again, with insurers and private equity in control, you can be pretty sure that the doctor you thought had your best interests at heart may now be directed to do things for you that may not necessarily be in your best interest, certainly at odds with what the doctor would have otherwise advised you to do and the care your doctor otherwise would advise you to get. So you're seeing the same person, but it may be a different doctor. And that's concerning. Now, it is possible, I just want to add, that maybe a DCE is possible. Maybe a DCE is going to operate in a way that helps doctors deliver better care. That's what CMS would like you to believe. The issue is really when you have private equity running the healthcare show or insurance companies, for-profit entities, whose job is to maximize profits and whose responsibility is to put shareholders' interests first. And doing so is to make sure that you are paying as little as possible for care because of the way that they are reimbursed, right? They are getting paid a flat fee. So if they're getting paid a flat fee and they can provide less care, they make more money. And so the concern again is, are they going to look out for your best interests, or are they going to look out for the best interests of their shareholders? And frankly, the best interests of their shareholders are what they are required to be, acting for.
Well, Diane, here's one of the man on the street. I've been writing my man on the street questions to myself here in recent weeks. But let's assume that I'm in a primary care practice and my doctor, joined a DCE, and things are going fine. We're talking, we're working with our doc, but I develop cancer, and my doctor refers me to an oncologist somewhere locally within his DCE network. But I say, doc, Moffitt in Tampa is one of the best in the country. I want to go to Moffitt. Can I ignore my doctor's advice? Can I go to Moffitt? Can I get a cancer specialist at Moffitt or Shands, and carry my Medigap G plan with me to Shands or Moffitt, and not have to worry about whatever advice my primary care doc may or may not have given me? I mean, that's the bottom line. That cuts it right to the chase.
That does, Jim. That really cuts it right to the chase. So the answer is yes. And why would you do that? Why would you have a doctor who you want to disregard? So yes, in theory, you can disregard the advice of your doctor and go to Shands or Moffitt because you know that's a better place to go for your cancer care. But don't you want to have a primary care doctor who refers you to the best possible place?
Yeah, you do. But I mean, the other thing, Diane, is second opinions, where You know, you go to the doctor that was referred to you by the DCE, by your primary care doc, and you get an opinion, but you're a wise, educated consumer of healthcare, and it is, by the way, your life on the line here. And you say, no, doc, I respect the opinion that I got from the person you referred me to, but I want to go to Shands and get a second opinion. And your doctor doesn't necessarily refer you to Shands. Can I just pick up and say, thanks, but I'm going to Shands. And
Yes.
when I get to Shands, they welcome me like they always do. If you have a Medicare G plan, you know, they give you a big hug because they know that they're going to get paid and they're not going to have to deal with an Advantage plan administrator. Can I still go to Shands and get that second opinion?
Okay, so you've really hit the nail on the head here, Jim. So the answer is, again, in theory, you can go to Shands and they will treat you. Over time, the question becomes whether Shands wants to take you as a patient, knowing that you're part of a direct contracting entity. Why would they not want to take you? If they're worried that somehow or other, they're not going to get paid for their care because of who's in charge of paying. Now, the truth is that if you're going out of network and you're in a direct contracting entity, Medicare pays the out-of-network provider directly.
Right.
And again, in theory, the direct contracting entity is not involved. But who knows how that's going to evolve? With Medicare Advantage, as we know, a lot of the centers of excellence don't want to have anything to do with Medicare Advantage plans.
Oh, understood. I mean,
they just don't. And that's why a lot of people don't choose Medicare Advantage, because they want to know they can go to Shands or Moffitt or Mayo Clinic, and they know that they can't in most Medicare Advantage plans. And what we don't yet know is how that's going to be any different if you're enrolled in a contracting entity.
And Diane, this is Bill, and there is a very key issue. There are no known rules. For example, there's nothing to preclude the thought that a privately run, Wall Street controlled organization would not set rules. For example, Medicare Advantage, you cannot sell a Medigap plan to a Medicare Advantage enrollee. Will that rule be the same, or will traditional Medicare transform current Medicare? Will these DCEs transform current Medicare such that they will include, let's say, out-of-pocket maximums, even though the government-controlled Medicare does not? Are they going to be free to add benefits over and above what traditional Medicare offers?
Excellent question, Bill. They are going to be able to do the same kind of luring people into their networks or into their systems.
They'll have a Joe Namath ad too.
Excuse me?
They will have Joe Namath ads, sponsorship.
They'll be able to have the Joe Namath ads. They'll be able to put in an out-of-pocket cap. They'll be able to suggest through their doctors that maybe you don't need a Medigap anymore. And if you listen to them and you drop your Medigap, then it's going to be virtually unaffordable for you to go out of their network. And
but also, if I'm in a Medicare Advantage plan, I need to be aware that they will be direct competitors, and that someday my costs are going to go up significantly because they have a competitive impact on Medicare Advantage plans.
Your costs could go up over time. I think that's an excellent point as well. So right now, what the DC model is designed so that your costs cannot be any higher in a direct contracting entity than they are already in traditional Medicare. But over time, with the Wall Street takeover of Medicare, you can bet a lot that your costs will go up considerably, because these insurers and private equity firms are in the business of making money. And the way they do that is to shift more costs onto enrollees. And they do that through making it harder to get care, forcing people to pay more for their care. Again, they can't do that right this moment in the DCEs, but over time, I think you have to expect that. And that's what we see already in Medicare Advantage. If Medicare Advantage is the model where the government is paying a fixed rate per enrollee, and this is the same with the direct contracting entities, what we're seeing in Medicare Advantage is delays and denials of care inappropriately, is what the Office of Inspector General has said. Widespread delays and denials of care inappropriately in Medicare Advantage. Why? Because again, the less care that the insurers cover, the more money they make. And it's the same with the direct contracting entities.
Okay, well, look, Diane, I really thank you and Jim for opening this up. And my guess is that just the small group that we have here today, we could probably go on for an hour with Q's and A's and concerns expressing. And so what I'd like to do is wrap it up here by saying, as I said at the beginning, this is all about cost. No matter who's the insurer, no matter whether it's public or private, it's the cost of healthcare. What's happening is that costs are running away 4 times the demand side. And we'll have to address some of that later on. But for now, I want to wrap it up and tell our audience that we would ask you to please go to www.nrln.org immediately after this podcast and click on the Respond to Action Alert link on the red bar at the top of the homepage, and email the prepared letters to President Biden and your representatives and senators to demand they kill direct contracting that would destroy Medicare. And you can personalize these as well. And I hope you do that immediately. In our next episode on direct contracting and DCEs, we're going to talk about additional information we've learned, and we'll answer some questions that hopefully you will have submitted. We'll also share information about members of Congress who are undermining retiree Medicare. That's going to be an interesting conversation. You won't want to miss it. Well, Diane and Jim and Ed, thanks so much for offering your time and effort today. You did a great job.
Thank you all.
Thank you.
The facts on the table. And I want to invite you back to help me respond and the NRLN and AREF respond to any follow-up questions that you could bring. And you could bring in the latest DCE information, particularly Diane, who's close to this every single day. And to our audience, thanks for listening. Please send us your questions and comments regarding this podcast and suggestions about what you think you need to hear regarding your personal health care and income security in future podcasts. I want to recommend you to read our January 3rd website posting of Time to End Taxpayer Rebates to the Private Insurance Industry, www.nrln.org, on the red bar on our homepage. Click on Legislative Agenda, then Talking Points to read our one-page summary, or click White Papers, scroll down to the Healthcare section, and click to read the 4-page paper. Our next podcast will be streaming to you live, we hope, and we will reveal what we have discovered and how seniors in Medicare are kept in the dark about best prices available when shopping for Medigap plans, an important thing for you to think about. Our suggestions may help reduce Medigap premiums. So watch for notices of dates, times, and subjects about content on our podcast at www.nrln.org. Thank you very much for your attendance and your attention.
Thank you all.
That's it. That's a wrap. The NRLN is your source for the truth about retirement benefits crucial to your future well-being and the health and financial well-being of your children, grandchildren, and our country. Stay current with news that affects you through our emails and our website at nrln.org. There you will find the links to follow us on Facebook and Instagram. On www.nrln.org, click the NRLN videos and podcast color icon in the middle of our homepage, then select a podcast episode or video to play. Watch for scheduled podcast topics, dates, and times. Sign up on the website to get emails and podcast announcements. Our podcasts are also posted on YouTube. On the NRLN.org taskbar, you can also click the Contact Us tab and select Contact the NRLN, where you can send an email or call toll-free 866-360-7197. Ask questions, offer suggestions, offer new topics, and sign up to get our NRLN messages, action alerts, and advance information about videos and podcasts. Until next time, stay safe out there and enjoy your life. And remember always, seniors are special.